Although most infants make the necessary biopsychosocial adjustments to extrauterine existence without difficulty, their well-being depends on the care they receive from others. We are going to continue with the assessment and care of the newborn. This will be part one. Care begins immediately after birth and focuses on assessing and stabilizing the newborn's condition. The nurse has the primary responsibility during this time. The nurse must be alert for any signs of distress and initiate appropriate interventions. A rapid assessment is performed. This assessment includes general appearance, respiratory system, cardiovascular system, neurologic system, gastrointestinal system, the eyes, nose, mouth, skin, the genitourinary system, and others such as obvious anomalies. The initial examination of the newborn can occur while the nurse is drying and wrapping the infant, or observations can be made while the infant is lying on the mother's abdomen or in her arms immediately after birth. Efforts should be directed towards minimizing interference in the initial parent-infant bond. If the infant is breathing effectively, is pink, and has no apparent life-threatening anomalies or risk factors that require immediate attention, further examination can be delayed until after the parents have had the opportunity to interact with the infant. The initial assessment of the neonate is performed immediately after birth using the Apgar score and a brief physical examination. A stable gestational age newborn assessment is completed within the first hours of birth. A comprehensive physical assessment within the first 24 hours of birth. Other procedures are performed immediately after birth, such as erythromycin ointment to the eyes and the vitamin K shot. In addition to the newborn, will need also footprints, an ID band, and security bands as soon as possible. Apgar, Apgar, read all about it. So you want to assess at least 1 minute and 5 minutes of age. The Apgar score permits a rapid assessment of the newborn's transition to extrauterine life based on 5 signs that indicate the physiologic state of the neonate. These 5 signs are the heart rate, which is based on auscultation with a stethoscope or palpation of the umbilical cord. Respiratory effort, which is based on observation of the movement of the chest wall. Muscle tone, which is based on the degree of flexion and movement of the extremities. Reflex, irritability, which is based on response to suctioning of the nares or the pharynx, and generalized skin color. It is described as pallid cyanotic or pink. Evaluations are made at 1 and 5 minutes after birth and can be completed by the nurse. Scores of 0 to 3 indicate severe distress. Scores of 4 to 6 indicate moderate difficulty. And scores of 7 to 10 indicate that the infant is having minimal or no difficulty adjusting. Apgar scores do not predict future neurologic outcome, but are useful for describing the newborn's transition to the extrauterine environment. The 5-minute Apgar score should have a higher rate than the 1-minute Apgar score. Now we will continue with the adaptations of the newborn, starting with the respiratory adaptations. So what affects the lung development? Well, during intrauterine life, oxygenation of the fetus occurs through transplacental gas exchange. However, at birth, the lungs must be established at the site of gas exchange. In utero, fetal blood was shunted away from the lungs. But when birth occurs, the pulmonary vasculature must be fully perfused for this purpose. We are going to review gestational age, lung fluid retention, for an example, meconium, birth congenital defects, fetal breathing, and movements in relation to the respiratory adaptations throughout subsequent lessons. It has been recognized that there are no single trigger for newborn respiratory function. It is a combination of factors involved with the first initial breath. The initiation of respirations in the neonate is the result of a combination of chemical, mechanical, thermal, and sensory factors. Let's review a few facts. Production of lung fluid decreases 24 to 36 hours before spontaneous labor. There's approximately 80 to 100 mLs of fluid that remain in the passageway of a full-term newborn. The babies will gasp and exhale, which initiates the removal of the fluid. And during labor, the babies will experience a glucocorticoid and catecholamine surge that promotes the fluid clearance. So, during the first breath, the lungs will expand and there will be an increase in pulmonary circulation. And with each breath, the alveoli will expand more. The remaining lung fluid is usually absorbed within the first 2 to 24 hours after birth. We are now going to discuss the combination of factors that are responsible for initiation of breathing, starting with the chemical factor. The first breath is an inspiratory gasp, triggered by an increase in PCO2 and decrease in the pH and PO2, which also will decrease. The changes trigger an aortic and carotid chemoreceptors, which triggers the brain's respiratory center related to the decreased levels of oxygen and the increased levels of carbon dioxide. The action of the cord clamping causes the prostaglandin level to fall, initiating the baby's respiratory drive. It also causes a rise in blood pressure, which increases circulation and lung perfusion. Respirations in the newborn can be stimulated by changes in intrathoracic pressure resulting from compression of the chest during the vaginal birth. As the infant passes through the birth canal, the chest is compressed. This pressure on the chest is released, and the negative intrathoracic pressure helps draw air into the lungs. Crying will also increase the distribution of air in the lungs and promotes the expansion of the alveoli. The positive pressure created by crying will help keep the alveoli open. Now we're going to discuss the thermal factor. With birth, the newborn enters the extrauterine environment in which the temperature is significantly lower. The profound change in environmental temperature stimulates receptors in the skin, resulting in stimulation of the respiratory center in the medulla. During this transition, cold stress must be avoided. The sensory factor occurs in a variety of ways with birth. The lights, the sounds, the smells, the physical contact, and procedures of the new environment that can be involved in stimulation of the respiratory center. At term, the lung holds approximately 20 milliliters of fluid per kilogram. Air must be substituted for the fluid that filled the fetal respiratory tract. Once respirations are initiated, they are shallow and intermittent. The respiratory rate varies with the state of alertness and activity after birth. Respirations are abdominal in nature and can be counted by observing or lightly feeling the rise and fall of the abdomen. Neonatal respiration should be counted for a full minute to obtain an accurate count because there are periods when respirations can cease for seconds and resume again. The rate will vary between 30 to 60 breaths per minute. Newborns breathe through their nose, known as nose breathers. The blockage of the nasal passageways can cause respiratory distress. The signs of respiratory distress include nasal flaring, intercostal or subcostal retractions, or grunting with respirations. So what happens is we have the aortic pressure increases and venous pressure decreases. Systemic pressure increases and pulmonary artery pressure decreases. There is the closure of the PFO, closure of the PDA, and closure of the ductus venosus. Hola! We have established respirations. As air enters the lungs, PO2 rises in alveoli, relaxation of pulmonary arteries leading to a decrease in pulmonary vascular resistance. This means blood starts flowing into the lungs. 100% normal blood flow to the lungs by 24 hours of age has been established. Successful conversion from fetal circulation to newborn circulation is dependent on this process. Okay, so let's talk a little bit about the increased aortic pressure, which decreases the venous pressure. An increased is caused by the clamping of the cord. The systemic blood pressure will rise, and then blood returns from the inferior vena cava, decreasing, causing a decrease in the right atrial pressure, and then a small decrease in pressure in the venous circulation. Now we're going to talk a little bit about the increase in system pressure and a decrease in pulmonary pressure by having a rise in the systemic blood pressure, and then the lung expansion increases to pulmonary blood flow, and then there's a sudden increase in PO2 that causes the vasodilation of pulmonary vessels, and this is from the initiation of breathing, and then of course it leads to the pulmonary vascular resistance dropping, and then the blood rushes into the pulmonary beds. Okay, we're going to continue with some cardiovascular changes that are related to initiation of respirations. Okay, closing of the PFO. When the baby breathes the very first time, the pulmonary vascular resistance decreases and there's an increase in pulmonary blood flow. This causes the pressure in the left atrium to rise because of the blood return from the pulmonary veins. Pressure in the right atrium drops and overall systemic vascular resistance increases as the umbilical flow is stopped when the cord is clamped. The change in atrial pressure closes the foramen oval. Closing of the PDA. The increase in pulmonary blood flow, which causes the increase in the oxygen concentration, as well as during the cord clamping, causes the drop in prostaglandin levels. Then oxygen causes the pulmonary vessels to dilate, but the ductus arteriosus constricts. This causes the ductus arteriosus to close. This is the official conversion to regular circulation. Functional closure starts about 10 to 15 hours post-birth, with complete closure by 4 weeks after birth. And then we have the closing of the ductus venosus. It's thought to be the result of a mechanical pressure changes that after cutting of the umbilical cord, there's a redistribution of the blood and cardiac output changes. And the closure usually occurs within the first 2 months. This concludes part 1 of the assessment and care of the newborn. If you have any questions, notify the instructor.